Hey everybody, this is my Aerogen Nevo project proposal. So the mission statement of the VA is to fulfill President Lincoln's promise to care for him who shall have borne the battle and for his widow and his orphan by serving and honoring the men and women who are America's veterans. So our organizational core values, VA has 5 core values that underscore the obligations inherent to the VA's mission: integrity, commitment, advocacy, respect, and excellence. Integrity is act with high moral principle, adhere to the highest professional standards, maintain and the trust and confidence of all with whom I engage. Commitment, work diligently to serve veterans and other beneficiaries, be driven by an earnest belief in VA's mission, fulfill my individual responsibilities and organizational responsibilities. Advocacy, be truly veteran-centric by identifying, fully considering, and appropriately advancing the interests of the veterans and other beneficiaries. Respect, treat all those I serve and with whom I work with dignity and respect, show respect to earn it. Excellence, strive for the highest quality and continuous improvement. Be thoughtful and decisive in leadership, accountable for my actions, willing to admit mistakes, and rigorous in correcting them. So the structure here of the medical center. So you're going to have your director and the assistant director up at the top. Ultimately, obviously, all decision making for the medical center goes through them. And then you have a director of patient care and nursing, and then you have the chief of staff, obviously for all the physicians in the medical center. So below them, you're going to have the chief of infectious disease and the chief of pulmonary medicine, who really are going to be kind of the big points that the proposal is going to have to go through. And below the chief of pulmonary medicine, you have your chief of respiratory, and then the staff RTs, and under the director of patient care and nursing, you have your day, evening, and night nursing supervisors, and then your staff RNs. So obviously, ultimately, going to the next slide here, the goal is to introduce the use of Nevo and Aerogen nebulizer units for NIPV and PPV patients to minimize the risk of aerosol generation, which ultimately protects staff and the patient population, while also improving outcomes in these patients that are in need of nebulized medications. So this is where ID and pulmonary medicine come in. Obviously, with the COVID-19 virus, you're seeing a lot of patients come into the hospital that might initially test negative, and then, after a few days in the hospital, become positive. And obviously, trying to minimize aerosol generation. So by utilizing these devices, with NIPV and PPV patients, it minimizes the amount of times that you have to break circuit, which obviously generates aerosol, and which in turn help reduce staph infections and intra-hospital transmission of COVID-19. And then talking about improving patient outcomes, we're talking about instances like VAP and stuff like that. So the objectives, as mentioned, decrease the risk of intra-hospital transmission of COVID-19 virus, while also improving patient outcomes in those requiring nebulized medications by improving medication deposition and reducing the occurrence of VAP. The functional objective, obviously, is to deploy the Nevo Aerogen nebulizers in the setting of patients requiring PPV and NIPV, and that are also in need of nebulized medications. The training objectives, so obviously all personnel who provide care and administer bronchodilators to patients requiring NIPV and PPV be trained in the use of the Aerogen and Nevo devices. So that's both staff, RTs and RNs. So the concept problem solution. So currently, the Providence VA Medical Center utilizes small volume nebulizers to deliver aerosolized medications. So in our NIPV and PPV patients, we have to break the circuit and put the small volume nebulizer in line to deliver these medications. And then each time the patient needs a nebulizer, you either have to, completely just take the SVN off, or you're unscrewing the bottom, etc. So every time you're opening or breaking the vent circuit, it's, associated with explosive depressurization, which is known to generate infectious aerosols while also interrupting, life support for those patients that are on PPV. And then breaking the ventilator can also increase the likelihood of microorganisms that can cause VAP. So every time you're breaking that circuit, you are increasing the chance of introducing microorganisms that then can cause infections, nosocomial infections in our patients, and ventilator-associated pneumonias. Utilizing the Aerogen and Evo vibrating mesh nebulizers with NIPV and PPV, it can help prevent, the intra-hospital COVID-19 transmissions, while also helping to prevent the occurrence of VAP, because you're not getting this aerosol generation every time you're breaking the circuit, and then you're also not getting the introduction of microorganisms into the vent circuit by, breaking it. And then also with patients that require nebulized medications, we have a pretty heavy COPD patient population in the Providence VA Medical Center, and the Aerogen has been shown that it can deliver up to 6 times more medication to the lungs, and there's many studies showing that it actually improves clinical outcomes through faster symptom and bronchodilator response because of that increased medication deposition in the lungs. So the feasibility of this. So ultimately, overall feasibility of this is really pretty high. The Aerogen device itself is extremely easy to use. It's literally, the medication cup, the T-piece, which, the RT will be placing in line on the device, or in the case of the Nevo, which is inserting it into the BiPAP CPAP mask. And then it's really just hooking up to the control module and pressing a button to turn it on, putting the medication in the cup. So overall, training wouldn't require a significant amount of time for training. And then, obviously, it's not going to require, any additional staff for training. It's just utilizing the existing staff that are here now. Really, the cost for this proposal primarily will be coming from acquiring the Aerogen and Evo modules, and then just the supplies for it. And then ultimately, from a savings standpoint, one, you're looking at reducing overtime potentially, because if you're reducing intra-hospital COVID transmission, then, you're minimizing staff members that are being out sick, which in turn is going to reduce overtime. And then also, if you're reducing the instance of VAP, now VAP obviously a little different for the VA, because we're covering cost of care as it is. If this was a for-profit hospital, obviously if you have VAP, then the hospital is responsible for covering the cost. But in general, still though, it's going to save the VA and the taxpayer money by preventing VAP. VAP is associated with an estimated increase of cost of care by $47,238 per patient. And on top of that, also, there's that risk of increased mortality with VAP as well. So budget and financials. Again, as I mentioned, you have your staff respiratory therapist, respiratory supervisor, chief respiratory, then your RNs. Like I said, there's no increase in staffing required for this. But yeah, so there's really no increase in cost of staffing for this. What you're going to see here is uh, you're going to see the biggest cost is going to come from the actual aerogen itself. At 8 modules, it would be a little over $15,000 for the modules, and then your the Solo Neb kits, and then the Nevo nebulizers here. I think this is being very generous for training time. Honestly, it could probably be done in a lot less of time for training. But, just setting aside 8 hours for training, going over policy procedures, that kind of thing, you're going to get this here, your total cost for RT training, and then your total cost for RN training. So again, not significant, and it's not like it's something that you're going to have really annual refreshers on, because it's literally putting a nebulizer in a cup and pressing a button to run it. So overall, I would say extremely low cost, and when you total up the cost of this, if you're saying on average one instance of VAP can increase cost of care by almost $48,000, if you can prevent 2 cases of VAP, you're pretty much covered the cost of this initiative itself. So, to me, it's pretty much kind of a no-brainer here, with the potential savings. And then, like I said, on top of that, the potential for saving overtime. If this is your, 8 hours of straight time right here, times that by time and a half, it can be potentially pretty cost saving too. So the timeline for the proposal. So initially, the first 2 months, December, January, gathering information supporting the use of the aerogen and Nevo nebulizer, gathering information on cost, presenting the information here over the next time period here, February, March, to infectious disease, the chief of respiratory, chief of pulmonary medicine, obviously because, again, ID, with VAP and COVID-19, and then pulmonary medicine because, these devices are going to be used in most likely patients under ICU care, which pulmonary is obviously running our ICUs. So, presenting this information to them. So, April, May, and then May, June, acquiring the devices, having the Aerogen rep come in for some in-servicing, and also at the same time training your staff RTs and RNs, or creating training materials for your staff RTs and RNs, and then the next few months here, May, June through September, October, this would be your time for training RTs, training your RNs, getting them situated with using the device. Again, like I said, this is honestly probably kind of generous on the time frame. Obviously, there's a lot more nurses than there are RTs in the facility, so it might just take a little bit longer to get them all together for the training. But again, it's easy. Giving 8 hours for it is kind of a generous amount, but this should be adequate time block to get everybody trained. So before that, through the whole time up to this, and even before the proposal, we can use the CPRS EMR to go back and gather information on patient outcomes, as far as readmission rates, hospital length of stay, in the intubated patients, how many times VAP has occurred, and stuff like that, which obviously will be used for our comparative data for our final presentation. And then after the implementation of the devices here, we would monitor these outcomes in these patients. Again, length of stay, occurrence of VAP, that kind of stuff post-introduction. And then, again, infectious disease, employee health would be able to give an idea on these figures here, the amount of intra-hospital cases of COVID transmission between staff and patients. So leading up to the initiation of use of the device, and then post-initiation use to see if there's any change in numbers. I mean, obviously, this statistic might be a little bit harder just because of the ebbs and flows of waves of COVID. But still, I mean, you can kind of compare slow periods to slow periods and busier periods to busier periods, and help determine, the comparison data on intra-hospital transmission. And then lastly, these months here, July, August of 23 through October 23, this here can be used to compare the data, get the report together, which ultimately, would present the findings to the hospital, which would then justify the use of the device, or if it's, just the keep using the device as we were before through the SVNs. And last but not least, these are my references for my proposal, and I appreciate you taking the time for looking at this, and I hope you have a good day.